Hello, this is Alex with our group assignment number 3. Today is October 25th, 2020, and we will be reviewing risks and complications of coronary angiography, a comprehensive review by Tavakol, Ashraf, and Brenner. That was posted in the Global Journal of Science. That was, it looks like January 2012. Anyways, so again, my name's Alex.
I'm Roland.
I'm Manpreet Singh.
And we will be reviewing our group assignment number 3. Again, so complications range widely from minor problems with short-term life-threatening situations and may cause irreversible damage during interventional radiology exams, particularly angiography, and if urgent care is not provided. Again, these are life-threatening situations. So fortunately, the associated risks have decreased significantly with the inception of coronary and arteriography due to increased equipment design and post-procedural management and increased experience of diagnostic centers and their operators. So there are no absolute contraindications to angiography other than the patient's refusal to the exam. So major complications are low in cardiac catheterization, only affecting 2% of those who undergo the exams and killing less than 0.08%. But recognizing these potential complications allow for the damage to be minimized. So we'll go over some of these complications that may arise, and after each covered section, there will be a competency check question for all the technologists on the cardiovascular team to review. So Manny, why don't you go ahead and take it off?
Oh, thank you, Alex. So one of the first subjects that I felt like that we should address are allergic and adverse reactions. Allergic reactions refer to exaggerated sensitivities, in a sense, hypersensitive reactions that occur when your immune system responds abnormally to a foreign substance, whereas adverse reactions, on the other hand, are an undesired harmful effect resulting from a medication or other interventions such as surgery. They may also be termed as side effects. In regards to coronary angiography, local anesthesia, general anesthesia, contrast media, prophylaxis and treatment, as well as heparin-induced thrombocytopenia can all lead to both allergic and adverse reactions. So moving on, let's go ahead and start with the first one here, local anesthesia. Allergic, local, and systemic reactions to local anesthesia are extremely rare, and systemic reactions refer to when inflammation spreads from a localized area of one organ, such as the skin, to other organ systems in the body, and the inflammation can be caused from toxins, allergies, or infections. Methemoglobinemia, which is a condition of elevated methaglobin in the blood. Symptoms may include headache, dizziness, shortness of breath, nausea, poor muscle contraindication, and blue-colored skin, or also known as cyanosis. This is one of the reactions. Complications may include seizures, heart arrhythmias, asthma-like reactions, vasodepressor reactions, are some of the other reactions in addition to methemoglobinemia. To kind of recognize vasodepressor reactions, it's also known as a vasodepressor syncope, which occurs when you faint because your body overreacts to certain triggers, such as the sight of blood or extreme emotional distress. May also be known as neurocardiogenic syncope. Vasovagal syncope causes your heart rate and blood pressure to drop suddenly. That leads to reduced blood flow to your brain, causing you to briefly lose conscious. And there's also anesthesia toxicity, which is also known as local anesthetic systemic toxicity, which we could abbreviate as LAST. Is a life-threatening adverse event that may occur after the administration of local anesthetic drugs through a variety of different routes. This life-threatening adverse reaction results from local anesthetic reaching significant systemic circulating levels. So LAST is rare and almost always occurs within minutes of injection of a local anesthetic. Most reports are with the older agents and have been infrequently reported with amide agents such as lidocaine. The amide local anesthetics, including lidocaine, bupivacaine, ropivacaine are commonly used for pain control during minor surgery or invasive procedures such as biopsies, small excisions, or dental work. Reactions are generally dermatologic, so having to do with the skin, or vagal, which refers to the vagus nerve, which is our 10th cranial nerve and is responsible for regulation of internal organ functions such as digestion, heart rate, respiratory rate, as well as vasomotor activity and certain reflex actions such as coughing, sneezing, swallowing, and vomiting, and are rarely anaphylactic, which relating to or caused by anaphylaxis. Anaphylaxis is severe, potentially life-threatening allergic to a reaction. It can occur within seconds or minutes of exposure to something you're allergic to, such as, certain things, like an example, peanuts or bee stings, common allergies such as that. The reactions that do occur are generally secondary to preservatives used in drug preparations, use of preservative-free agents such as the bupivacaine, as I mentioned earlier, and skin testing would be warranted in patients with a history of reactions to local anesthetics. So before we continue, is anyone able to pronounce that better? Okay, that was the best attempt there.
You got it, buddy.
Okay. So just as a competency check, what is a local anesthetic systemic toxicity, or LAST?
That's a life-threatening adverse event that may occur after the administration of a local anesthetic drug.
Very good. Very good, Roland. Just wanted to double check that there. Moving on to general anesthesia. General anesthesia is not routinely required in the catheterization laboratory, or shortened to cath lab, and a majority of procedures take place without an anesthesiologist. Conscious sedation and analgesia, which, in other words, the inability to feel pain with short-acting agents such as midazolam or fentanyl at low doses, are commonly used to increase patient comfort and release anxiety during the procedure. In these situations, proper care must be taken to prevent the patient from being over-sedated. It is important to closely monitor the patient's blood pressure, heart rate, respiratory rate, and oxygenation. When hemodynamic compromise, which that refers to when your blood does not clot, or over-sedation occurs, the use of reversal agents for benzodiazepines and opiates should be promptly administered. Anaphylactoid reactions happen infrequently with conscious sedation agents and are much more likely to occur following administration of contrast media. Treatment of any adverse reactions depend on its severity and includes the potential use of oxygen, bronchodilators, epinephrine, histamine blockers, corticosteroids, and intravenous fluids. In cases of severe anaphylaxis, not responsive to conservative management, and when I use the word conservative management, it refers to a type of medical treatment which avoids invasive measures such as surgery or other invasive procedures, usually with the intent to preserve function or body parts. In that case, endotracheal intubation and urgent consultation with the anesthesia team must be performed, and reviewing the patient's histories and their allergies can help avoid unnecessary exposure to patients with previous allergies or adverse reactions to local or systemic anesthesia. So pay attention to allergies to seafood, as patients with this allergy can have an allergic reaction. Iodine containing contrast media. Make sure you ask the patient further questions. So moving on, we'll go ahead and talk about, actually, let's go ahead and have a little question here. What is conservative management best defined in your guys' opinion?
Ooh, me.
Go for it, Alex.
Yeah. So conservative management is a type of medical treatment which avoids invasive measures such as surgery or other invasive procedures. And that is to preserve the function of the body or body parts. So to take place in case of severe anaphylaxis, you want to make sure that they have an ET tube, an endotracheal tube, with the anesthesiologist and anesthesia team prior to that.
Yeah, very good, very good, very good. Moving on, we'll move on to third section here in regards to contrast media. So in regards to adverse reactions involving contrast media, they may be classified as either chemotoxic, which refers to toxicity due to chemical effects, or anaphylactoid, those reactions that produce the same clinical picture with anaphylaxis but are not IgE mediated. and occur through a direct non-immune mediated release of mediators from mast cells or basophils, or result from direct complement activation. So in a sense, contrast media can activate an anaphylactoid response through histamine release. This differs from an anaphylactic reaction in that it is not immune mediated and does not require prior sensitization to the offending agent to initiate a reaction. Chemotoxic effects, for the most part, refer to hyperosmolarity, ionic content, viscosity, and calcium binding properties of these agents. All contrast agents are based primarily on iodine and is combined to a benzoic acid ring in a mixture of meglumine or sodium salt of diatrizoic acid with calcium EDTA. So in order to achieve the iodine concentration that is needed for optimal visualization during angiography, solutions of conventional contrast agents are extremely hypertonic. So adverse reactions are common in ionic high osmolarity contrast agents, reported greater than 50% of patients in some studies. Milder constitutional symptoms such as warmth, pain, chest tightness, nausea, and vomiting are frequently reported. And adverse reactions such as hypotension, arrhythmias, pulmonary congestion require intervention. So the introduction of lower osmolar ionic agents and water-soluble low osmolar non-ionic dioxylin have significantly lowered the incidence of hypersensitivity and adverse reactions. Patients with advanced age, higher or CHF class, history of prior contrast reaction, and elevated left ventricular diastolic pressure are 6 times more likely to develop adverse reactions with high osmolar ionic agents. So the need for risk stratification initially arose from the high cost of newer low osmolar agents, which was at one point 10 to 20 times that of conventional high osmolar agents. Selective use of these agents in appropriate populations has been shown to decrease overall cost by 66% with improvement in safety and cost effectiveness. So the cost of these agents, however, has decreased significantly over the past 10 years, allowing for widespread use of the low osmolar agents to prevent adverse reactions at only a small difference in price. So the introduction of the non-ionic agents have had some concern due to evidence suggesting that ionic contrast material exhibited a more pronounced antiplatelet and antithrombotic activity, especially in vitro studies. So these properties may be beneficial during a procedure that may damage the vascular endothelium and cause thrombosis. So before we move on, a quick competency question. What is the difference between a chemotoxic and anaphylactoid reaction?
So anaphylactic reaction.
I got this.
Yeah. Oh, you got it. Okay.
Yeah, I was waiting for this after the first one. So anaphylactoid contrasts stimulate histamine response versus chemotoxic have hyperosmolarity and interact with and have ionic content which interact with your cells. In essence, I'm sure there's a lot more to that, but
nope, that's a great answer. Good job. So moving on, let's go ahead and talk about prophylaxis and treatment. So it is possible to prevent allergic reactions to contrast material. There are 2 categories of patients at risk for developing anaphylaxis that should be considered for pre-treatment. Patients with previous anaphylactic reactions are at highest risk for developing recurrent reactions. The second category involves patients with a history of atopy, which refers to genetic tendencies to develop allergy diseases such as allergic rhinitis, asthma, and atopic dermatitis, as well as asthma. There's no consistent cross-reactivity that has been demonstrated in patients with allergies to food containing iodine, seafood, and contrast anaphylaxis risk. And I previously just mentioned the word cross-reactivity. So when I mentioned cross-reactivity, it's the reactivity of an observed agent which initiates reactions outside the main reaction expected. So allergic reactions occur when the proteins in one substance are similar to the proteins found in another substance. So for example, if you're allergic to, I'm using this as an example. So if you're allergic to birch tree pollen, you may also find that eating apples causes a reaction for you. So in this case, we should always Be sure to ask further questions when encountering patients with a history of allergy to shellfish or seafood and a history of atopy or asthma. This is useful as it identifies the patient at highest risk for developing anaphylaxis. In addition to the type of contrast agents, pre-treatment with prophylactic medications is a critical part of preventing recurrent reactions to the population at higher risk or at highest risk. So corticosteroids and histamine blockers are the cornerstone of pre-treatment. The low cost and high safety profile of histamine 2 blockers have made them a common component of treatment in many cath labs, and its effectiveness, however, is controversial, and consistent results have not been shown in prospective trials. So before we move on to the final section here in regards to allergy or adverse, the different types of reactions, why is it important to ask the patient further questions if they have a history of allergies to like shellfish or seafood in our field?
I can take this. So it's important to ask for any type of allergies because they can develop anaphylactic shock if they're like severely allergic to that specific food and seafood or shellfish allergy, because we do give iodine, which is similar in substance, so they might have a reaction. So we want to ask. And then how severe are the reactions if it's mild or moderate? And if it's severe, yeah, you got to like prepare.
Correct. Good job.
Yeah.
Good job. All right. So moving on here, we're moving on to heparin-induced thrombocytopenia, also abbreviated as HIT, is a serious immune-mediated complication of heparin administration from flush, heparinized saline, or during percutaneous coronary interventions. So although the risk will not be manifest during the procedure, the clinical symptoms that develop in the days after the procedure can have a devastating thromboembolic complications in patients with a prior exposure to heparin. So patients with underlying coronary artery disease and patients with a cardiac transplantation have a higher incidence of HIT, about 2 to 8% and 11%. And severe patients have been described in whom an acute coronary syndrome occurring during coronary angioplasty in association with an onset of HIT. The diagnosis is based on the clinical procedure of platelet decrease with or without association thrombosis. Among the patients with HIT and thrombosis, 9 to 11% require limb amputation, and mortality is reported in 17 to 30%. So treatment includes immediate and complete discontinuation of heparin and initiation of treatment with direct thrombin inhibitors such as argatroban, bivalirudin, and lepirudin.
Nice.
Thank you. In patients with or at a risk for HIT who present to the cath lab, prospective trials of those, I'll pronounce it again, bivalirudin and argatroban have demonstrated safely and efficacy. Yeah, so moving on, who has a higher incidence of HIT?
So those with higher incidence of HIT are typically patients that already have underlying coronary artery disease, CAD, or patients with cardiac transplantation, since they are already on a regimen of heparin blood thinners. So yeah, that's why.
Good job. Good job. All right. So now that we've covered those reactions to that, as I previously mentioned, let's move on to infections. So an infection is a disease caused by a microorganism that invades the tissue. It occurs when another organism enters your body and causes disease. The organisms that cause infections are very diverse and include things like viruses, bacteria, fungi, and parasites. So something we're all familiar with, right? So let's move on to incidents. Infections are rare after invasive cardiovascular procedures. Most signs and symptoms are unlikely to develop immediately following the procedure. The most common organism found in studies was coagulative negative staphylococcus, and none of the patients developed clinical signs of infection. Fever is a relative contraindication for elective procedures, and patients with ongoing infections should be appropriately treated before an elective cardiac catheterization. So local infections after angioplasty have been related to early repuncture of ipsilateral femoral artery, use of arterial grafts for access, and retention of catheters for prolonged periods. Insertion of a Foley catheter prior to the procedure should be noted as a potential cause of complicated urinary tract infection, and their use should be avoided when possible, and when inserted, removed when urine output monitoring is not further warranted. So before we move on to the infectious precautions, what have local infections after angioplasty been related to?
So local infections related to angioplasty are, what is it? Repuncture of the ipsilateral femoral artery, use of arterial graft for access, and retention of catheters for prolonged periods.
Good job, good job. All right, so moving on to infectious precautions. The American College of Cardiology does not recommend the use of strict operating room sterile techniques for most catheterization procedures. So hair removal should be considered if there is an interference with obtaining access to the site. When removal is necessary, we utilize electric clippers, and they should be used, and the use of razors should be avoided. Skin cleansing with a 2% chlorhexidine-based preparation such as ChloraPrep should be used prior to local anesthesia. The use of masks and eye shields may provide more protection to the operator to avoid blood splattering during the procedure. And following the procedure, the use of occlusive dressings, and when I say occlusive dressings, I'm referring to a non-permeable dressing, which means that no air or moisture can penetrate in or out, and topical antimicrobials, and by that, I'm referring to agents or chemical substances that, when directly applied to the skin, inhibit growth or destroy any microorganism, either fungi, viruses, or bacteria. So just a quick check. What should be utilized following the procedure to prevent infection?
So to prevent infection, this goes pretty standard for any surgery. But again, you want to use an antimicrobial, something like betadine, directly to the skin that will kill and inhibit any growth of microorganisms. And then, of course, that occlusive dressing you're mentioning, that is non-permeable, so that will seal off the puncture site from infection.
Good job, good job. So moving on to the last section here that I have, we're going to be talking about nephropathy. So nephropathy is a disease of the kidneys caused by a damage to the small blood vessels or to the units in the kidney that clean the blood. So in regards to coronary angiography, contrast-induced nephropathy, which we'll abbreviate as CIN, C-I-N, is a serious complication of angiographic procedures resulting from the administration of contrast media. It is the third most common cause of hospital-acquired acute renal injury and represents about 12% of the cases. So pre-existing renal insufficiency, diabetes, age, along with osmolality and volume of contrast used are the most significant risk factors to developing CIN. So we'll go ahead and start with prevention and prophylaxis. Multiple individual risk factors have been reported for the development of CIN. Of the modifiable variables, minimizing the volume of contrast medium administered in the primary defense against CIN. Radio contrast dosed was the most powerful independent predictor of the nephropathy requiring dialysis. The overall volume appears to be more relevant in patients with baseline chronic kidney disease who have a 5 to 10-fold increase in CIN when more than 125 to 140 milliliters of contrast is administered, irrespective of other preventive measures. Therefore, most experts actually recommend a limitation of contrast volume to 3 milliliters per kilogram. And the success of peri-procedural hydration can be extended to patients with chronic renal failure through continuous venous hemofiltration. Hemofiltration allows for the administration of large volumes of fluid without the associated risk of fluid overload. So the last question that I say before we move on to the next topic is, what is nephropathy and what was the most powerful independent predictor of nephropathy requiring dialysis?
All right, so nephropathy is a disease of the kidneys caused by damage to the small blood vessels or to the units in the kidneys that clean the blood. And the most powerful independent predictor for it is a radio contrast dose that the predictor of nephropathy requires dialysis.
Good job, good job. So I'll end my part there and we'll move on to the next portion.
Okay, great. So moving on to some of the other issues that can happen when you are receiving angiographic interventional radiology procedures are cholesterol-based emboli. So cholesterol-based emboli are released usually from weak vascular spot plaque as the instruments travel through the arteries or vessels. So they're typically released during angiography from the lower extremities. These symptoms include discoloration of the extremities and a purple webbing pattern on the skin, which is known as livedo reticularis. Other symptoms include digital cyanosis. So cases of cholesterol emboli progress to the kidneys approximately 2 to 4 weeks after angiography. The cholesterol emboli are then diagnosed through biopsy of the affected tissues. And it also states that only 2% of cases demonstrate cholesterol emboli. So many are asymptomatic, and autopsies demonstrate a higher incidence percentage of 25 to 30%. So actually these happen pretty often. Primary risk sources originate in the ascending aorta with minimal risk differences related to the brachial or femoral artery approach. So increased risk factors include increased age, repeated procedures of IR exams, and history of atherosclerotic disease. So treatment is also pre-procedural use of simvastatin and support during the exam in the event of an embolism. So there's not really too much you can do. So again, what are some of the treatment options to prevent cholesterol emboli in IR cases?
I got this one. So as you just mentioned, treatment is pre-procedural and the use of simvastatin and support protocol in event of an embolism.
Yep, not too much you can do.
Right.
So moving on, something that can happen during IR procedures is local vascular injury, damage to the vessel due to the procedure. So vascular injury is the actual most common and significant cause to morbidity and mortality of angiography. So increases in pharmacotherapy, so drugs that are given, have decreased incidence of angiographic complications and prevent bleed out, including early sheath removal, avoiding placement of venous sheaths, and careful monitoring of heparin dose as potential ways to decrease bleeding risk and complications. Also increases in imaging equipment and advances of digital radiography have also allowed smaller catheters, smaller sheaths to minimize the impact on vascular structures, narrowed vascular structures in particular. So these advances have lowered vascular complications from the time frame in 1998 to 2007 from 1.7% to 0.2%. So pretty drastic decrease in the scope of things. And in percutaneous coronary intervention from 3.1% to 1%. So again, pretty significant decrease. So the next section of local vascular injury is hematoma and retroperitoneal hemorrhage. So poor hemostasis technique after sheath removal can cause hematoma. So if you remove it too quickly, it will cause that large blood mass on the femoral axis site. So many hematomas are not really of concern, yet large hematomas may cause a deep vein thrombosis, DVT, nerve compression, and sensory loss. So quick application of compression after discovery of these hematomas should be used for 20 to 30 minutes to reduce chance of hematoma. Prompt removal of the axis sheath within 2 to 4 hours. With prompt removal of the axis sheath along with several hours of bed rest following the removal will help. So large uncontrolled hematomas should suspect laceration of the femoral artery. If this occurs, crossover sheath should be inserted into the opposite femoral axis site, and the bleeding site should be located via angiography in the event of uncontained bleeding. So the blood loss can be controlled by inflating angioplasty balloon or deploying a graft stent at the site of where the damage to the vessel occurred. So retroperitoneal bleeding is potentially life-threatening complication of arterial axis as well, which is more frequent when the artery is punctured above the inguinal ligament, so higher up from the femoral artery. Such bleeding is typically not evident from the surface and should be suspected if the patient develops some sort of abdominal pain or flank pain along the back, along with hypotension and decreased hemoglobin levels. So that is monitored during the exam. CT scans can then be used to confirm clinical suspicion, and early recognition should be is paramount to ensure that the application of manual compression and administration of fluids or blood are applied. So the those at most risk for these hematomas or retroperitoneal hemorrhage are those of older age, those that are female or with low body mass and low surface area within the vessels. And it's also more prone for those with higher femoral artery punctures, and is actually synergistic with those significant risk factors for retroperitoneal hematomas. So most patients can be managed with reversals. Most patients can be reversed with anticoagulants, compression of the access site, observation, and blood transfusions as necessary. So when conservative management has failed, tamponating, which is otherwise known as blocking the bleeding site with some type of cloth or chemical, or via puncture or via balloon angioplasty, may also be performed. So what demographic is most at risk for retroperitoneal bleeding?
I remember this one. Older age, female gender, low body mass, and low surface area.
Awesome. Great.
Cool.